So I think we have quite a few students here now. We should start. So in today's session, we are going to cover two topics of the maternal medicine. Dr. Z, can you hear me now?
Yes, thank you very much. Sorry, it was a mistake on my side.
Okay, that's fine. What's your name?
Zahra.
Zahra. Okay. Okay, Zahra. So in the today's session, we'll be covering two topics of the maternal medicine. First of all, I welcome you all on this platform of MedExam Expert. Thank you so much, all of you, for joining us for this today's session. So in the today's session, we'll cover the maternal medicine topic in the essence that we will start from the very basis. We'll discuss the template of maternal medicine first, and then we will practice two stations. Now, one will be simulated patient task SPT station, and the other one will be an ST station, a structure discussion. So I would like you all to participate actively and volunteer for the both the SPT and ST stations. So for the new candidates, for the May and for the November, I hope they know that the exam is 168 minutes. There are 14 stations in the Osler system, and there is a small break after the 7 stations. And then we have got 3 type of stations. So there is a structure discussion in which there is a direct viva with the examiner. We are all aware of this type of station because we've all been taking exams, the viva exams, during our medical career. Then the second type of stations will be those with the simulated patients. So there will be 3 people. There will be a candidate, the examiner, and then we'll have to communicate with a simulated patient. These are the professional actors, and they will act like patients. Then the third type of stations is those which are simulated patients with the lay examiner. And these are the stations which carry the highest marks because not only the examiner will be marking you, but also a lay person who is not from obs-gynae, they will be assessing you as well. They will assess your communication and they will mark you for the domains as well. So in the exam, what are we tested for? We are tested for 4 domains: the information gathering, communication with patient and relatives. It can be communication with colleagues as well, and then applied clinical knowledge, and of course the patient safety. So these are the domains which we will be tested for. So coming to the topic of maternal medicine, it is a very vast topic. And if you know the essence of the maternal medicine, then even if there is an unknown station, or if you have read it quite a long time ago, then you will be able to grasp it if you know the basic essence of the station. Okay, so I will start with a template for the maternal medicine. And I would like you all to participate actively. You can even write in the chat box so that we know that we are all audible to each other. Okay. So when we talk about any station, any simulated patient task station, if there is a structured discussion, you can simply introduce yourself to the examiner that, hi, I'm Laila, one of the exam candidates, and I'm ready for structured discussion. That will be simple and straightforward. However, if it is a simulated patient, then you'll have to introduce yourself to the simulated patient. So you can say that you don't have to copy anyone else, you just have to be yourself. Okay, but however, for the exam, you need to cram up some lines so that during the stress of exam, you are not stressed out, and that you can make some lines for yourself which you are going to ask in the introduction or say in the introduction. So basically, in the introduction, first you have to greet the patient and then confirm their name and age to make sure that this is the right patient that you are talking to. So you can say that, hi, I'm Laila. I'm one of the doctors in the clinic today. May I check your name and age, please? And if, for example, patient says, my name is Jane, Jane Phillips, then you can say that, what would you like me to call you? She says, Jane is fine, and then you can say, please call me Laila then. So this is the simple introduction. Don't make things complicated, just be yourself and keep things straightforward. Then we'll come to the agenda. So in the agenda making, also try to make it simple, keep it simple, and don't complicate it. So whatever, why the patient is here today, that is the patient's agenda. So you just have to put that in your words. For example, in the maternal medicine, if the patient has come with diabetes, she is, for example, at 32 weeks, this is her first pregnancy, and she is here to discuss the care plan. So all you have to say that, I understand that you are, this your first pregnancy and you are 32 weeks into it, and that you have a condition, diabetes, and you are here to discuss the pregnancy care plan with us. Is that right? So that's how you are just going to put in the words the patient's agenda, whatever the patient is here for. For example, if the patient is for preconception counseling, then you can say that I understand that you're keen to get pregnant and that you have a condition, diabetes, and that you are here to discuss the care plan with us. Is that right? And then patient says that yeah, that's right. You can even ask her, in order to extract more knowledge from the patient, or in order to clear your agenda, if there is any doubt, you can say that, is there anything in particular that you would like to discuss today? Okay, so you can even ask that from the patient to extract any hidden agenda or anything that particularly the patient is here to discuss. Maybe the patient will say that I'm here to discuss the birth plan. So then you will know that your main focus is the birth plan. So you don't need to waste your time on the rest of the pregnancy care plan. Okay. So Dr. Monica, can you give it a try just to do an introduction with the patient?
Hello, I am Dr.
Hi.
Monica, doctor in the clinic today. May I check your name and age, please?
Yes, doctor. My name is Jane Phillips.
How do you want to be called?
You can call me Jane.
Jane, I have gathered from your notes that you have come to discuss about your pregnancy plan. Am I right?
Yeah, that's right, doctor.
Do you have any other concerns? And what is the expectation out of this consultation today?
Yes, doctor. So I'm particularly concerned about how this is going to affect me and my baby during the pregnancy, and what can be done to reduce the risks.
Your concerns is that. Before that, shall I ask you a few questions to know about you so that we'll be
Yes,
able to
sure.
discuss about your plan? Okay.
Yes,
Jane,
sure.
please tell me about your condition in your own words.
Yeah. So perfect, Monica. That was a very good and very concise agenda making. So we have to do is just to put the agenda in the words. Okay. All right. So well done.
Thank you, ma'am.
Yes, very well done. Okay, so then coming to the history of presenting illness, first of all, we'll ask about the current pregnancy. If the patient is in the preconception clinic, we don't need to, so these questions will be skipped. And then we'll straight go on to the medical condition that she has. However, if she is pregnant, then the first question has to be an open question. Okay, this is the key. So the first question is open question. So the essence of the open question is that you will extract more and more information from the patient in just one question. So you can say that, may I know more about your pregnancy? Maybe she will say that this is my first pregnancy. It was a planned pregnancy. I'm 30 weeks into this, and the pregnancy has been fine so far. So your rest of your questions will be saved. Okay. So may I know more about your pregnancy? Then the next question, is this your first pregnancy? Was it a planned one? If it was a planned pregnancy, then you can say congratulations. And then how far you're pregnant, how has the pregnancy been so far? If the patient is in early pregnancy, you can ask about the early pregnancy question. For example, are you taking folic acid? May I know your blood group? Have you been booked to the antenatal clinic? Is your dating scan, booking bloods and down screening done? And do you know the result? Okay, so these are the question that you have to ask if the patient is in early pregnancy. Um, However, if the patient is in late pregnancy, like advanced pregnancy, third trimester, then you don't need to go to the booking stuff. Just skip it so that your time is safe. You can come straight that, can you feel the baby kicks? blood group is for all the patients. So from all the patient, you'll have to ask the blood group. There's certain situation in which we are expecting blood transfusion, there is a risk of surgery, all those things. Then you can ask about any objection to blood transfusion as well to rule out Jehovah's Witness. Okay. Otherwise, in routinely, you don't need to rule out Jehovah's Witness in every case. Then in the late pregnancy, we'll also ask about any scans or blood tests that were done recently. So we want to know about the recent tests, not the booking bloods and all that stuff. Okay. And then will come the medical condition. So in the medical condition, you can again ask an open question, so that she will give you more and more information about her medical condition. Okay, because the patient knows best about her condition. So she will just put into words all the questions that you have in your mind, the answers for all the questions. So for how long she had this condition, how does it affect her, what is the current control, what is the current treatment, when was the last visit with the doctor, any recent test that she had. And you can also ask that, have you been recently unwell or admitted to the hospital? So that will just complete the picture and you will get an idea of the medical condition that she's in. Then of course we'll complete the rest of the template, ask about obstetric history, her previous pregnancies, the mode of delivery, how was the recovery. Then in the gynecological history, her LMP, her cycle regularity, contraception, cervical screening is very important. In the preconception, you have to ask from all the patient. However, if the patient is pregnant, then only in the high risk patient, like those with HIV or renal transplant, you can ask about the cervical screen. Then the medical conditions, any surgery, how was the recovery, any diseases that run in your family, any drug history, any medication that she's taking, if she has any allergies. If the patient is saying that she don't have any other medical conditions, so there is no need to ask about any medication that she is taking. Okay, so just to don't waste your time on any extra questions. If the patient don't have any other medical condition, she wouldn't be taking any medication. Okay. Allergies are very important. You have to ask from every patient. And once you ask it, you have to make a note of it into the patient's chart. So you have to say it that, okay, I will write it down in your chart. I will make a note of it in your chart so that the examiner knows that you are taking it seriously. Okay, so then comes the personal history. In the personal history, we'll ask about her BMI. You don't need to say the weight to height ratio because the role players there are aware with the word BMI. And even with the weight to height ratio, they can even get confused. So just say that, may I know your BMI? May I know if you have missed the blood group, you can incorporate it here in the personal history or blood group. Do you smoke, drink, or pardon me to ask, take any recreational drugs? Or if you want to make it concise, you can even ask that, is there any social habits or personal habits that might affect your health? So that can cover all of these as well. Okay. And then social history and mental history. How are things at home? What do you do for a living? How have been you feeling lately? Okay, so am I being clear so far on in this history template? And do we have any questions up till now? You can write it in the chat box, and you can even ask me. You can unmute yourself and ask me. Memuna is here, Jaspa is here as well. Thank you, girls, for joining us. Maruf is here. Okay, so I suppose we don't have any questions up till now. So then comes we'll move on. So then comes the history and examination. In the oscillator systems, there is no examination. So there's no marks for it. You don't have to waste any time on it. You can just skip this bit and go on to, if there is any investigation, you can move on to that part. So in the investigation, if there is any blood tests, any report given, it is a patient safety point that you have to say that you have to check the patient's name and NHS number on it. And you have to say that you need to say this, that I have checked your name and NHS number on the report, and the report says this. Okay. So very important to confirm the patient's name and NHS number. Then we will, after completing your template, the history template, you will discuss the medical condition a little bit. So for all the medical conditions, you can make certain lines. A journal template would be that, for example, Jane is the patient. Jane, the condition you have, diabetes. Most women who have this condition, they go on to have a healthy pregnancy and childbirth. However, there can be certain effects for you and for your baby as well. Okay, so keep the explanation very simple. Don't try to complicate it. Keep it in simple and short words. So then you will discuss the effects on mother and on the baby, and then comes the antepartum care, the intrapartum care, postpartum care. Then coming back to today's agenda is very, very important, because, for example, if the patient is coming for preconception counseling, then you have to discuss why she is here today and address the patient's concerns. Then you can make a short summary of what you and the patient has agreed on today. By making there should be some closing sentences as well. Then you will write a letter to a GP, the medical consultant, give patient information leaflet to the patient, and connect her to a support group. And at the end of the station, don't forget to say thank you for coming to see us. Okay, so that this is going to be a complete template for the maternal medicine. Do we have any questions so far? If we have any question, you can ask right now, and then we will move on to practice the SPT station. Memuna, are you there?
Yes, Dr. Laila, I'm here.
Hi, Memuna. Do you have any questions so far?
No, it's very clear. I think the template is clear.
Okay.
The
You are appearing in the May exam or the November one?
May exam.
Okay. Okay. Best of luck, Memuna.
Thank you.
So we will now move to the one of the stations. Memuna, are you happy to volunteer for the SPT?
Yes, Dr. Laila, I would like to.
Okay. So we will set the timer for the 2 minutes. So we have 2 minutes reading time, and then 10 minutes is the time for a performance. Memory, you have the oscillars, right?
Yes, Oscar. Online exam, yes. I can't see the scenario.
Yes, sure. So your 2 minutes starts now. If you have read the scenario, then we can start, okay?
Okay, the 2 minutes are over?
2 minutes are not over yet. You still have 40 seconds.
Okay, just
Take your time.
Okay, I'm ready to start.
Okay, let's start.
Okay. Hello, my name is Dr. Maimuna, one of the doctors in the clinic today. Can I please confirm your name and age?
My name is James Phillips, and I'm 29 years old.
Okay, Jane. So I gather from your that you are here from your notes that you are here to discuss your blood reports, and that you want to conceive and you want to conceive, and that's why you're here to discuss your reports. Is that right?
Yeah, that's right, doctor.
Okay, Jane. How about I ask you a few questions to know more about your history and to understand your concerns in a better way, so that we'll be able to come up with a management plan which is safe and mutually agreeable. Is that okay?
Yeah, that's fine, doctor.
Okay, so starting off, Jane, can you please tell me more about your concerns or what your expectations specifically from today's appointment that you want to know specifically? Do you want me to cover specifically?
Yeah, so me and my partner, James, we have decided that we should start a pregnancy and settle down and start our family of our own. But
Mm-hmm.
because I have this condition of diabetes, I was particularly
Okay.
concerned about how it is going to affect my pregnancy. And then if there is any risks and what can be done to reduce the risks.
Okay, Jane, I will try to address all your concerns. Is it okay if I ask you a few questions before starting?
Yeah, sure.
Okay, Jane, so can you please tell me for how long have you been trying to conceive?
Actually, I have been, we have just decided now that we should start a pregnancy. And
Oh,
that's why I went to
mhm,
my GP. And because I have this condition, so my GP took some bloods, and then he
mhm.
asked me to see you in the clinic.
Okay.
So the
So before that, okay, yes, please carry on.
yeah, for the preconception counseling.
Okay, so Jane, were you using any contraception or birth spacing before this, or are you currently using any?
Yeah, so I have been using Depo-Provera for the last 3 years.
Okay, and when was the last injection?
I am due for one now.
Okay, so around 3 months ago, right?
Yeah, yeah.
Okay. Apart from that, when were you diagnosed with diabetes?
So I have diabetes since childhood, and
Okay.
yeah, that has been a long time ago.
Okay, and you're using insulin for that, right? Only insulin.
Yes, I'm using only insulin.
Okay, and do you visit your doctor regularly and how's your blood sugar control?
Um, so the thing is, doctor, that I have been really busy in the last couple of months in my law firm.
Mm-hmm.
I'm a solicitor, so there has been some up and down in the blood sugar levels.
Okay. Okay.
Yeah.
So, okay, I see. I understand that. Jane, can you please tell me whether if you have ever felt any sweating or whether your blood sugars were really down, so you had to be admitted, or the blood sugars were up, so that you had to be admitted because of that?
No, I haven't been admitted recently.
Okay, and have you had your eyes and kidney checkup done?
Yes. So that was both of these were done around 5 months ago.
Okay, I'll make a note of that. Also, do you have any high blood pressure or any proteins in the urine or any other complaint?
No.
Okay, when was your last period?
So my last period was almost 1.5 months ago, maybe.
Okay, so are your periods regular? Do you have any complaints with your periods, any pain or any such complaint?
So you see, my periods are very infrequent and very scanty.
Okay, and have you taken any medications for that? Any treatment for that?
So actually, I have been using this Depo-Provera, and that's why
Okay,
yeah, my GP
okay,
told me that I'll be having infrequent periods because of that.
okay, okay. Do you have any history of any surgeries in your tummy or down below?
Um,
No. Okay, and this is the first time you're trying to conceive, right?
yeah.
Okay. Any other family history of concerns?
No.
Can I know your blood group?
My blood group is AB positive.
Okay. Do you smoke or use alcohol apart from asking any recreational drugs?
No.
Okay. Do you know your BMI?
My BMI is 32.
Okay. I'll make a note of that. Okay. Now, so is there anything else that you want to add?
Um, yeah, I think doctor, that's all.
Okay, thank you for answering my questions, Jane. So, coming to your report, I can confirm I've confirmed your name and NHS number. And according to this report, your sugar levels, this report basically shows your sugar levels over the past 3 months. And according to this report, the levels are a little bit on the higher side. Are you following me?
Yeah, doctor.
So basically, these higher levels can have certain implications in your pregnancy, which I'll explain shortly. So basically, what happens is that if the sugar levels are really high, it can have certain implications for the mother as well as for the baby. For the baby, what can happen is that baby can have certain anomalies because of these high sugar levels, such as certain problems in the heart or in the brain. These can occur. Also, the baby can have chances of a miscarriage or pregnancy loss, also delivering early before time, and can also, in some cases, die inside the womb. Are you following me?
Yeah, doctor, but that is very serious.
I don't just mean to scare you, but the purpose of telling you is that I want to know that a regular follow-up and proper control is very important, okay? And it can also have certain impacts and implications for the mothers as well. Having pregnancy with diabetes can have certain implications, such as the mother can have miss early pregnancy loss. She can undergo she can have the control of sugar during the pregnancy can be really difficult. Also, there can be certain problems with the she can have high blood pressure, proteins in the urine. She can have certain problems with the delivery and labor. She can have increased chances of going into cesarean birth. There's also chances of the baby's shoulder being stuck, and also there's can be certain problems after the delivery as well. Are you
Okay,
following
doctor.
me?
Yes.
Okay, yeah, so the purpose of me telling you these is because that we need to follow you in a regular way, and we need you to show up for your appointments. And for your preconceptual counseling, is basically what is important at this point is that you need to start folic acid, 5 milligram high dose folic acid. We'll start you on that. Secondly, we would advise you to lose weight because BMI is slightly on the higher side. Are you following me?
Yeah, but is there any effect for that? Is that going to affect my pregnancy?
Yeah, certainly, Jane's high BMI can affect pregnancy in a lot of ways. There's increased chances of blood clot formation in the legs. Also, there can be increased chances of baby having certain anomalies, increased chances of the sugar control worsening, having blood pressure. So all these can you can have these problems during the pregnancy if the weight BMI is above 30. So we'll certainly encourage you to lose weight. So as this can be a complicated pregnancy, so your pregnancy will be managed by a team of doctors, which would include a consultant, a dietitian, a nutritionist, and an exercise specialist to help you lose weight. And also will liaison with your GP and your medical specialist who's in control of your blood sugars. Okay.
Okay, doctor. Yeah.
Okay, and certainly there's another thing that I would like to address that you've been taking Depo, right? Injection
Yeah,
Depo
yeah.
Provera for your birth pacing. So coming to that, basically, what we see is that generally women who use Depo Provera for birth spacing, they can have a delay in return in their fertility for about up to 1 year. So it might take you some time to conceive. But in the meantime, this is an opportunity for you to control your blood sugars by monitoring your blood sugars. Can you monitor your blood sugar yourself?
Yeah, I think I can do it. But from now onwards, I'll be more cautious about it.
Yeah, that's really good, Jane. So this is basically an opportunity for you to bring your blood sugars in control so that you can have a pregnancy with a healthy baby and a healthy pregnancy. Also, you can inculcate certain lifestyle measures in your life. You can try to lose weight. For that, we'll connect you to certain concerned dietitian and nutritionist as well, which will help
Okay.
you to embark upon a healthy pregnancy. Okay.
Okay, doctor.
So, are there any other questions that you would like to ask?
Um, is there any special measurements that will be taken during the pregnancy?
Yes, certainly. Basically, during the pregnancy, you in the beginning will ask you to continue folic acid for the first 12 weeks. You'll also undergo a dating scan early between 7 to 9 weeks, and then we'll have another scan, a detailed scan to see the baby in detail, especially the hearts and other abnormalities if there are any. Also, we like to assess you for a need of any blood thinning medications throughout the pregnancy. You will have regular follow-ups. Your blood sugars will be controlled and will be monitored regularly. So, and you'll be followed up by a team of doctors throughout your pregnancy. during around 36 weeks of pregnancy, we'll discuss the management plan with you. And since you have diabetes, so you probably might have, if if you do not start labor on your own, you might have to start the labor around 37 to 38 weeks using certain tablets. And after that, after the labor, even you can have we'll also be assessing you for needs of any blood thinner medications. You'll be followed up in a consultant-led unit. Will be followed by a consultant doctor, and he will be monitoring. We'll be monitoring you throughout labor and delivery, and also after the delivery, we'll check your blood sugar levels. We'll discuss contraception, breastfeeding with you, and also how to manage your blood sugars after the delivery as well.
Okay.
So coming back to today, Jane, what we'll do is that we'll liaison with your medical doctor who's in charge of your diabetes, and also write back to your GP. I'll give you certain patient information leaflets, and we will monitor your HbA1c every month until it is in control. And we'll also advise you to start using folic acid. Okay?
Okay. Thank you so much for
Okay,
your time, doctor.
okay, thank you so much. Thank you. Okay.
Very well done, Maimuna. That was a very good presentation. How did you find it?
I actually was really confused. I think I mixed. I thought I would go in a sequence, but in my mind, everything got messed up. So I was just going from this point to that point. So I don't know. So
That's completely normal. You see, this is why we need to practice more and more,
yeah,
because in the
yeah,
exam you just have to be calm and composed. Basically is the exam of nerves. So you just have to be very calm, and because you know all the things, you knew
yeah,
everything in the diabetes, like you knew the whole guideline. You just need to come stepwise. Okay.
yeah. Yes, yes, that's true.
So
Well, thank you for giving me the opportunity. I think it really, it really helped me. I just I got a
thank you
chance
for
to rest
joining us, and
myself.
thank you for
Yeah,
volunteering. So
thank you.
let's discuss some of the good points. It was your communication is very good. So the intro was good. Um, you can ask the patient, and you should ask the patient that what would you like me to call you. Maybe the patient wants to be called
Mhm.
Mrs. Phillips. Maybe she wants to be a bit
Okay,
formal, but most of the patients, they will be very friendly, so she will say that you can call me Jane. So just try to make these are the basic, cram these lines, because in the exam the screens will be just shifting back to back in the oscillator system. So you need to make these lines, the introduction lines has to be very perfect. Okay,
okay,
so try to practice these things more. That
okay,
hi, my name is Laila. My name is Memuna. I'm one of the doctors in the clinic today. May I check your name and age, please? What would you like me to call you? Okay, so these things you should not miss. Then comes the
okay,
agenda. Your agenda was very good. So in the agenda, all we have to say is that I understand that you are here because you are keen to get pregnant, and that you have a condition type 1 diabetes. Okay, so that's good.
okay,
Very simple. And you did ask about her particular concern. So that is also a good point, that from the start of the station, you know the patient's agenda. Okay, and then
okay.
we came to the first question was not an open question, Memuna.
Yes, I forgot that.
So
Yes,
you said that when were you diagnosed with the diabetes?
mm,
That was your first question, right? So
yes,
the
yes,
first question has to be an open question. You can say can say that can you tell me more about your condition, diabetes? So
yes.
maybe she will open up more, and maybe she will give you more information that will save some of your time. Generally, these stations of the pre-conception counseling, they are generally very long stations. So all
Mm-hmm.
we have to do is to try to save more and more time, because in this station, the basic template is you have to cover history, you have to cover
Mm-hmm.
the examination bit, investigation bit, and then you have to do the complete antepartum, intrapartum, postpartum care, and then coming back to the preconception. So it actually takes a very long time to complete this station.
Yes.
However, because like if we practice more and more, of course
Mm-hmm.
we can do this. So then the good points were that you asked about the kidney and eye checkup. You can ask about the last visit to the doctor. The current treatment was insulin. That was good. And then you did ask about the control, which were a little bit erratic. And if the patient says not very good control, you can even ask that, may I know the concern behind it? For
Mm-hmm.
everything that you are not sure why this is happening, you can ask the patient that, may I know the concern? There is no harm in asking the patient, so that you will clearly know that what is happening. So she said that she was very busy in her job and she didn't look after very well after her. So maybe that's why
Mm.
the her sugars were a little bit erratic. Okay,
Yeah,
and
okay.
then so that's when you covered the medical condition, and then we came to the obstetric history, the gynecological history. Her last period cycle was irregular because of the depot, and
Depot,
you
yes. I know.
yeah. So the depot, I would suggest that you in the start of this station you asked about the contraceptive history. So you
Mhm.
can even incorporate it here in the gynae history as well, because when you asked about the contraception in the start, you forgot to ask the first open question,
Yes,
isn't
yes,
it?
definitely. Yes,
So,
definitely.
so if you hadn't asked it in the start, the contraceptive history, maybe you would have, like, go in your flow of asking the routine open question. Okay, so
Yes.
it's better to incorporate here in the gynecological history. You could have asked about the smear because she is in the preconception clinic.
Mm-hmm.
Okay, and
Yes.
then you just ask about the surgical history, the family history. Memuna, did you ask about the allergies?
No, no, I did
No.
not.
Okay, so
Mm.
if this patient says that yes, I am allergic to penicillin, what will you say?
Okay, I'll make a note of that. I'll make sure that it is, write it down in your notes and everybody knows, every concern, all
Perfect,
the concerned people know.
perfect. So don't. What you have did now that you said three sentences just for answering one query of allergies. She is allergic to penicillin. Okay, I will write it down in your chart. That's enough. So you don't need to
Okay.
say that the concerned person and this and that, because all saying more words and saying more sentences, that will consume your time. So just try to
Okay.
answer things in one sentence and very concise and comprehensive. Okay,
Okay.
so that's that. And you did make it. So when you ask about the blood group, you did make a note of it. That was very good as well. You did ask about her BMI, you did ask about her personal habits, smoking, alcohol, recreational drugs. You can make it concise by asking that these personal habits, that do you have any personal social habits that might affect your health? So that can cover these things as well. And then the social history and the mental history. How are things at home? How have you been feeling lately?
Yeah.
These type of um, then we came to the um, um, investigation. Did you ask? Did you confirm her name and NHS number?
Yes, I did that.
Okay, perfect.
Yeah. I
So
said I have
just
confirmed your number and it is.
yeah, so that is one of the patient safety point, that you have to very important to confirm the patient's name and NHS number. And in the explanation, you did explain about diabetes, so you can do slide one or two sentences about her BMI as well. That the other
Okay.
concern is that your BMI is raised, so maintaining a
Mm-hmm.
healthy weight for your height before embarking the pregnancy will help us to have a healthy pregnancy and childbirth. Okay.
Okay.
And then you beautifully discussed the baby effects on the baby, on the mother. And then you went on straight to the preconception counseling. I would suggest that first you go through the antenatal care, the intrapartum care, the postpartum care, and then come back to the preconception counseling, and coming back to today. So in the last part, then you can do the preconception. You
Okay.
give the patient information leaflet, you connect it to GP, the specialist. These are all the good points. So very well done, Mamuna. Okay.
Okay. Thank you. Thank you so much, Dr. Laila.
Welcome here. So now I'm going to show you the slides for the complete template. So in the HOPI, we asked about the first question was open, has to be an open question. Tell me more about your condition, for how long she has the condition, the current control, current treatment, last visit with the doctor, any blood test she had, HbA1c done. Okay, and then renal and retinal assessment. um what is the time limit for the retinal assessment, Memuna? For if it was not done in last how many months, then you will repeat it.
3 months, I think.
Last 6 months
Mo-
for the
six
preconception.
months.
Okay.
Okay.
Last 3 months in the antenatal patients.
Okay. Okay.
Okay. Then we came to the obstetric history, the previous pregnancy, mode of delivery and recovery if the patient has been pregnant before, her LMP cycle, contraception, and smear. Very important to not miss contraception. in the preconception, because she has to be on some contraceptive before she goes on to have to the pregnancy, because she has the medical condition. So we need to first control the medical condition. Okay. And then medical, surgical, family history, drug history, allergies are very important, and try to make a note of it. Then BMI, blood group, also make a note of it, and then the rest of the personal history, social, mental. And at the end, Memuna very beautifully asked that, would you like to add anything to this information? So if there is any hidden agenda, anything that forgot to ask, patient can add it at this point. Okay. So then we discuss the effects on mother and on the baby. The effects on mother is that Jane was the patient, right? So Jane, most women who have diabetes and they have pregnancy, they go on to have a healthy pregnancy and childbirth. However, there can be certain effects for you and for the baby as well. And that's why it is very important to be compliant with the medication and have regular checkups. So certain effects that the condition can have for you is that there is increased risk of blood pressure during the pregnancy, along with the protein in urine. It puts you at increased risk of blood clots. You might go early into the labor. Once you are in the labor, your labor might be prolonged. There is increased chance of cesarean section and of anesthesia complications. Once the baby is born, there is increased risk of excessive bleeding and of wound infections. Okay, so you can just simply the antenatal, then the antenatal, the intrapartum, and the postpartum effects that it can have. Then comes the effects on the baby. So there is a risk of pregnancy loss, abnormalities in the baby's brain and spinal cord. The baby might grow bigger in size than the duration of pregnancy, and that's why there can be a risk of injury to the baby during the birth. There is a risk of death of the baby around the time of delivery and after the baby is born, and there can be an up and down in the minerals in the baby's blood. Okay, so that's how we are going to put into the words the effects on the mother and the baby as well. Ishil is asking that which thing we have to do at 6 months. Ishil, if it was the renal and retinal screening, if these are not done in the last 6 months, then you have to repeat it in the patients with diabetes. Okay. Sabine will definitely give you the chance in the next structure discussion station. Okay. Then you can also say that the demand for insulin will be increased in the pregnancy, and however after birth the demand is reduced. You will be looked after by a team of doctors, which will include my consultant, the diabetes specialist, a specialist midwife, and a dietitian will adjust the dose of insulin for you. We advise you to take folic acid 5 milligram higher dose till 12 weeks, and from 12 weeks onwards, aspirin 150 milligram throughout the pregnancy. We'll have your kidney and eye checkup done during the pregnancy. You'll have a dating scan, a scan to look for the abnormalities in the baby, and we'll serially do some growth scans for the baby. We'll assess you for the need for blood thinners. We'll do your blood pressure and urine check at every antenatal visits, which will be once every 1 to 2 weeks in a joint clinic with your diabetes specialist. Okay, so can someone tell me that anyone, open question for everyone, that what are the indication for folic acid 5 milligram?
Yes, it is because if someone has a previous neural tube defect affected child, or
Yeah.
if he or her partner themselves have a neural tube defect, like personal history, or if there is family history of neural tube defect, and then other minors are like diabetes type 1 and folic acid associated defects, and I think thalassemia, sickle cell
Yes.
disease. Yeah.
Yes. So who is this?
Sabine.
Sabine. Okay, Sabine. So Sabine, the preconception folic acid 5 milligram, and the one that is to be continued until the first trimester. So 5 milligram plus first trimester. What are the indication? Neural tube defect, history of neural tube defects,
Yes.
diabetes
History of neural
mellitus,
tube defect. Yeah.
and BMI greater than 30. So these are the
Okay.
three indications. Okay,
Okay.
Sabine.
BMI
So
greater than
these are the
30.
three indications for up to 12 weeks. And
Correct.
those where you have to use 5 milligram throughout the pregnancy. So that will be sickle cell disease, thalassemia, and epilepsy. So those three are the indication for 5 milligram throughout the pregnancy and
Throughout the
preconception as well.
pregnancy. Sickle
Okay.
cell, thalassemia, and epilepsy. Okay. Thank you.
Epilepsy, yeah, preconception and throughout as well, 5 milligram.
Mhm.
And the first one was 5
For
milligram
the
just
mhm,
until first
third
trimester.
trimester, first trimester. Yeah.
First trimester. And Sabine, can you tell me as well that for this patient, how much aspirin should we give? Because the
It
price
is.
guideline says, yeah,
Yeah. It
75
is.
to 150.
It is. I'm not sure. I think 82 to 162. Right. These days we are giving little higher dose.
So just according to the guideline, we will because the patient is a higher BMI, right? So any
Hmm.
BMI which is more than 30 for obese patient, you give 150 milligram.
150. Yeah. Okay.
Okay. And then we can also prescribe vitamin D as well. So can anyone else tell me that how much vitamin D will be giving to this patient?
Can I?
Ma'am?
Yeah, sure.
Hmm.
I think it's 10 microgram.
Ma'am?
Yes, so 10 microgram is for the routinely which we give, right?
Okay.
1000
And
units.
for
Yes, ma'am.
Okay.
routinely we'll give 10 microgram. And for those patients with BMI more than 30, then we'll give 25 microgram.
Okay. All right.
Okay. So the 10 microgram is equivalent to 400 international units. That is what we routinely give. In the patients who have history of preeclampsia, we'll give 20 microgram. That will be equivalent to 800 international units. And for those who have raised BMI more than 30, who had bariatric surgery, who had limited exposure to the sun, dark skinned people, so these here we'll give 25 microgram, and that will be equivalent to 1000 international units. Okay, girls. So are we clear on this now? Okay, and in the chat box, I can see that Aisha is saying 1000 international units. Yes, Aisha, that's right. So for BMI more than 30, it will be 1000 international units, and that will be equivalent to 25 microgram. So Aisha, can you tell me that how are we going to, is this an indication, this patient for the thromboprophylaxis? Can anyone tell me?
If the patient has diabetic nephropathy, then the score is 3 and we have to give thromboprophylaxis from 28-week onwards.
Yes, perfect. So diabetic nephropathy will make it a score 3. And then we will start it from 28 weeks onwards. And any patient who has had antenatal thromboprophylaxis, they will have it postnatally for 6 weeks as well.
For 6 weeks.
Yeah, perfect. So, right. Now let's move to the next slide of the intrapartum care. So in the intrapartum care, Mamuna, you'll have to organize a little bit yourself, okay, dear? So antepartum care, then come to the intrapartum, and try to cram these things, because this is the diabetes is a you just have to be very particular. Intrapartum care, the consultant-led unit that has a neonatal unit. So if you are speaking to a patient, you will be seen in a consultant-led unit that has a baby unit. Timing of birth will be at around 37 weeks to 38 weeks and 6 days. We will aim for the vaginal delivery. We'll continuously monitor the baby's heart. We'll monitor your blood sugars once every hour during the labor, and we'll give you an insulin glucose drip to maintain the blood sugars. Okay. And then comes during the labor, we have to maintain the levels to 4 to 7 millimole per liter. And then comes the postpartum care. So once the baby is born, we'll give you an injection to prevent excessive bleeding. And we encourage you to breastfeed the baby. We advise you to use suitable contraception, but avoiding the combined pill. We'll assess you for the need for blood thinners. We'll again adjust the dose of insulin for you, and the baby will be seen by the baby doctor. Then coming back to today, we'll arrange a consultation with your specialist doctor so that your sugars can be controlled, that the wake up sugar levels should be between 5 to 7, and before meals should be 4 to 7. We'll have your the the test that your GP had requested for the 3-monthly record of sugar, we will repeat it once every month to make it safe for you to get pregnant. The levels should be less than 6.5%. We'll have your kidney and eye checkup. We advise you to take folic acid 5 milligram, and have your rubella immunity checked. We advise you to maintain a healthy weight for your height and stop the Depo-Provera, as it may take 1 year for the fertility to return. However, during the meantime, you can either use a pill so that for the next 3 months, so that your health can be optimized during this time. So at the end, you can just say that Jane. So Jane, we have agreed that you will see your specialist doctor. Until then you can use the folic acid, and once you get pregnant, we advise you to go to your GP to have you booked in the antenatal clinic, so that we can see you from the very beginning of the pregnancy. I'll give you a patient information leaflet. I'll connect you to a support group. We'll write back to your GP and to your specialist. And you did check the understanding very beautifully, Mamuna, and you gave the information in chunks. That was very good. And at the end, you also asked that if there's anything else that the patient would like to be discussed. So if you have time, I would suggest that you do ask the patient at the end of the consultation that is there anything that she wants to be discussed, because in the exam the role player do come up with some certain things that might not have been covered in the consultation. So very good, Mamuna. That was a very good presentation, but we certainly need to improve upon certain points. So that was all about diabetes. Do we have any other questions? I'll show you the key. So in the patient safety, you need to assess the patient concerns and idea, respond sensitively to the patient question. It should be an agreed, acceptable, safe management plan. You need to be honest about the implications. You need to confirm the patient's name and NHS number on the report. Advise the patient on the importance of appropriate follow-up and treatment. Provide information on early booking. We have to do it in all the preconception clinics. At the end, save some time to say that once you do get pregnant, advise you go to your GP to have you booked in the clinic, antenatal clinic, so that we can see you from the very beginning. Then folic acid high dose and the assessment of diabetes control. In the information gathering, we did take a concise and relevant history, the diabetes history, and then the rest of the template was covered. Sorry. My slides have got a little bit haphazard.
And excuse me, doctor, how to talk about the mode of delivery, about induction, vaginal birth, and cesarean section?
You can just say that we will aim for vaginal delivery, and the timing of birth will be at around 37 weeks to 38 weeks and 6 days. If there is no there shouldn't be if there is no specific indication for cesarean section, then we don't need to talk about cesarean section specifically.
Okay,
right?
all right.
Because
yeah,
we aim for the vaginal delivery.
If we suspect large for gestational age, then we can say about the induction, right?
Yeah, definitely.
37,
So
after 37.
Yeah, so that will be a completely different scenario in which it will be an antenatal patient. And if, for example, the patient is large for gestational age, so in those stations, what you will do, that you will say that the baby is measuring a bigger than the duration of the pregnancy. Then you will discuss the implication. Then you will come to the plan where you will say that we'll organize a scan at around 36 weeks, where we will estimate the baby's weight and see if there is any excessive water around the baby. And so then you say that another scan will then be performed to estimate the weight of the baby at around 38 to 39 weeks. And if may I know who is this?
Sabine.
Yeah, so Sabine, I will ask you a question that if it is a large for gestational age baby, the weight is around 4.5 kilos. So what will you do?
So if large for gestational age and 4.5 kilogram, and if she is non-diabetic, then I will do nothing.
Induction of labor at 40
Induction
weeks,
of labor. Yeah,
at 40 weeks. Because it is a large for gestational age, okay?
Yeah, but if she is not diabetic, then also I will induce her.
No. So if the patient is so for non-diabetics, it should be greater than 5 kg. Then you
Yes,
will go for
greater than
cesarean
5.
section.
Yeah.
And
Oh,
for the
okay.
diabetes, if it is more than 4.5 kg, then you will go for a cesarean section.
Uh,
Otherwise, you will induce.
okay. Okay. So if she is diabetic and more than 4.5 kg estimated fetal weight, then I can offer her about the induction in order to reduce the risk of shoulder dystocia, right?
More than 4.5 with diabetes, cesarean
Yeah.
section.
Oh, okay. All right.
Yeah. So
Okay.
if less than 4.5 kg, then you can
Then
offer
induction.
induction. Yeah.
Okay. All right. Get it. Get it. Okay. Thank you.
Okay, because it is LGA. So in
Yeah.
LGA, if more than 5 kilos non-diabetic, cesarean.
Mm-hmm.
LGA diabetic, more than 4.5 kilos, cesarean.
Okay.
Okay, otherwise you can offer induction. In
Hmm.
the induction, you can say that we will kickstart the labor by giving you certain medication. Or for the cesarean section, you can say that I'm afraid that we'll have to offer you a cesarean section to reduce the
Mm-hmm.
risk for the baby and for you as well.
Okay.
Okay. So then communication with the patients and colleagues. Uh, the communication with colleagues domain is very, very important. All you have to say is the team of doctors and name the team of doctors. And then there you will be ticked for the communication with colleagues domain. So very important to not miss it and incorporate it in your discussion. So MDT, in the communication with patient, you did greet, introduce, and check the patient's name, set the agenda, assess patient's perception, describe the impact of diabetes while avoiding jargons. I'm glad that Memuna almost didn't use any jargon, so that was very good. Check the patient understanding, address concerns in an empathetic manner. Then coming to the applied clinical knowledge. So applied clinical knowledge was MDT, the impact of diabetes on pregnancy and baby, the preconception counseling advice, and the management during pregnancy. And then, of course, the most important, the contraceptive advice as well. Okay, so that was all about diabetes. May I know, do we have any other questions? Dr. Rafia is here as well. Dr. Rafia, do you have any questions regarding diabetes?
Ma'am, may I
Any
ask some question?
Yes, who is this?
Ma'am, Dr. Ishit.
Please come back again.
Uh, Dr. Ishil.
Ishwari?
Ishil, ISHIL.
Ishi, okay.
Yeah. I want to ask that since we have 10 minutes to discuss the whole of the topic of diabetes, so will we have to give some time also for the patient to question and then also answer them, especially when the part of communication with the patient, because whatever we have to say, we also have to know whether patient is understanding and comprehending those statements as well. And was one statement I was reading in one of the other scenarios relating diabetes, that we have to also ask the patient to repeat what we have said and give them full marks. That was written in the examiner key. So if we are doing that as well, so how we will cover in 10 minutes? Otherwise, we have to be speedingly, we have to
Yeah,
say things and which will be just like a tape recording
keep recorder,
like
yes,
type.
yes. Yes,
So
you're
ma'am,
right.
how we will be doing the if I want to say that how we will give the impact to the examiner, that we are sure that the patient is also comprehending. So I don't know how to do that in 10
Yeah,
minutes.
you have
So
your question is very valid, and it is a struggle actually. But you see, the examiners and the patient, both of them know that you have those 10 minutes. There's no more time. So the role players are also very like they don't try to drag you around something. If you answer their query, they will be happy. So they don't like if you are answering their query, you are actively listening to them, you're acknowledging what they are saying. So active listening is very important. If the patient, if you ask that, tell me more about your condition of diabetes, then she says, yeah, I have diabetes since childhood. You can just don't just sit there blankly. You can either do some nodding and then making some eye contact, or saying something, yeah, yes, I see. So all these are communication with the patients. So if you are doing these things, you are keeping the patient engaged. That is all which is about the communication with the patients. And then giving the information, if you, for example, you cover the information gathering, then you said that you is there anything that you would like to be covered, so she will come up. So it's not just you who is talking, you will also give some slight chance to the patient as well to talk. Okay, and then after the information gathering comes your bit where you have to talk now from the effects on the mother and the baby. So after doing every step, for example, you told about the effects on mother and baby, then you can say that, am I being clear so far? Are you with me so far? So after every chunk of information that you have given, make sure that you ask the understanding of the patient. Okay.
Okay, ma'am. Okay.
So
Thank you so
after the
much.
intrapartum, antepartum, and postpartum care you completed, now you ask that, am I being clear so far? Then you gave the preconception counseling. And then at the end of the session, Mamuna very beautifully asked that, is there anything else that you would like to be discussed? So the whole examination, the discussion should be the patient's agenda. You just have to follow the patient, what patient wants from us. And don't try to be, you rightly said that you don't have to be a tape recorder and just ditto copy the templates which has been given to you and then bombard all the knowledge onto the patient. You have to give the patient some time to react and react with the patient as well. So both of you are mirroring each other, you and the role play. It's just like a normal discussion in the clinic. So all you have to do is to be calm and composed and just sit back and relax and do a discussion with the patient. Okay. So I hope I
Okay.
have made my point clear. And the other thing which how you can achieve this, Ishi, that you can, the only way to achieve this is by doing more and more practice. You have to have a study buddy and you have to practice with them on the daily basis.
Okay.
Okay, so that is the key.
Thank you so much, ma'am.
You are very welcome, dear.
Dr. Laila, I would like to appreciate you for such an informative session. Thank you so much.
Dr. Afia.
Jazakallah.
Do you have any questions from the diabetes?
Doctor, about time of delivery. Or if she is on insulin, so time of delivery it will be 37 to 39 weeks. If it's on diet alone.
So generally the type 1 diabetes patient, they wouldn't be on diet alone. These are the GDM patients who are usually on diet alone, right?
Yeah.
Who is this, please?
Yeah, I mean gestational diabetes. I mean gestational diabetes on diet alone.
Yeah. Gestational diabetes on diet, the induction time is 40 weeks and 6 days, isn't it? According to a NICE guideline.
Okay, so you mean 40 to 41, it could be like that. It's possible to
Yeah, that's fine. That's perfect. Who is it, please?
Anam, doctor.
Anam, okay. Okay, so that's, yeah. So the patients on diet are usually the GDM patients. So for them, yeah, it is completely safe to say that around 40 to 41 weeks will start the labor.
Okay, doctor. If it's complicated and she's an insulin or whatever, and if she's complicated, so it will be earlier before 37 weeks?
Yeah, it will be earlier before 37 weeks.
Now you mentioned,
exactly.
Yeah, doctor, you mentioned about big baby. You mentioned that 36 weeks there's ultrasound and 38 to 39 weeks we repeat ultrasound. If it's big baby, then when we induce or when we do cesarean section exactly in such big baby, time of cesarean section or induction?
Yeah, so as I said that if the big baby has, mother has diabetes, and then there are big babies where mothers don't have diabetes. So if the patient is having diabetes and she has a big baby, so that is a complication of the diabetes, right?
Yeah.
So then we have to kickstart the labor before 37 weeks because we have diabetes, we have a complication of diabetes, and we have to deliver this baby. However, if there is no diabetes, it is only LGA. Okay. So only LGA. You will do a scan at 36 weeks. You will see the estimated weight of the baby. You will see the amount of Liker. Then you will do another scan because you don't have diabetes or any other thing. It's just LGA, right?
Yeah.
So you will do another scan at around 38 weeks and 38 to 39 weeks. Then you will estimate the weight of the baby. If weight of the baby is more than 5 kilos, you will go for cesarean section. If it is less than 5 kilos, you will start the induction at 40 weeks.
40 weeks, yeah. Okay, so it's 40 weeks. Yeah, doctor, in this case of LGA, if it's big baby, shall we do OGTT, oral glucose tolerance test, in such gestational age, like 36 weeks?
If the patient was type 1 diabetes, so we already know that she has diabetes. However, if it was
No,
just
no,
an
doctor.
LGA,
No,
yeah,
not diabetes. I mean, she's just LGA. So shall
yeah,
we do oral glucose tolerance test at 36
yes,
weeks? If
yes,
yeah, okay,
yes, we have to do OGTT.
okay,
Okay,
okay, thank you.
because if the patient has you do OGTT, if it is deranged, then you will refer her to the dietitian as well.
Yeah.
Sorry to bother, ma'am. One
Yeah,
question.
sure.
Usually we do OGTT between 24 to 28 weeks. If patient is LGA and she reports at 32 weeks or 36 weeks, so we have doubt. Even her OGTT is normal at 24 to 28 weeks. So we have to repeat again.
Yes, because the baby is LGA and you don't know the cause of LGA, so you have to find out something. So you have to do an OGTT.
Okay, even in later gestation, ma'am.
Yeah, because the sensitivity of the test will be reduced, although, but you have to do it.
Right, ma'am. Thank you. Thank
Who is
you.
this?
Shaista, ma'am.
Okay, okay, Shaista. So shall we move on to the next station? This one is going to be a structured discussion. Sabine wanted to do the structured discussion. Sabine, are you still online?
Yes, I am.
Okay. So I'll give you 2 minutes. And then, so your 2 minutes starts now.
Okay.
Have you seen your domains?
No, I want the second slide. Yeah.
So these are the domains that you will be tested for, okay?
Okay.
And then this is the candidate instruction. If you are ready to start, Sabine, let me know so we can start even early, okay?
Okay. Okay, I can start now.
Okay. So would you like to introduce yourself, Sabine?
Okay, sorry. Okay, my candidate number is 123, and I have read the scenario and I'm ready for structured discussion.
Okay, or you can even say that I'm one of the exam candidates and I'm ready for structured discussion. Okay, because
Okay.
it will be difficult to remember your candidate number in that stressful
Mhm.
situation. Okay,
Yeah.
so yes, your time starts now.
Okay. So, how to classify ICP?
Yes, that's the first question, how to classify ICP.
Okay, so intrahepatic cholestasis of pregnancy is classified according to the maternal, based on maternal history and according to the differential diagnosis.
Mhm.
And the differential based on like differential diagnosis could be some autoimmune conditions, could be some infections such as hepatitis B, C, and dermatological condition of the pregnancy such as pemphigoid gestations. Then it could be a pre-eclampsia of the pregnancy and primary biliary cirrhosis. So
Okay, and if it is intrahepatic cholestasis of pregnancy, how would you classify it on the severity of the symptoms or on the investigations?
okay, well, so severity of symptoms would be excessive itching. I will ask patient about excessive itching, particularly time of the itching, and the areas where she had most of the itching. And then I would ask about the rash. And also I would ask about the any other general symptoms such as fever, malaise, or tiredness, and then presence of jaundice. I would also like to ask about her color of urine, color of stools. So based on these symptom severity, it will be classified.
So how should the diagnosis of ICP be made?
And diagnosis of ICP will be made if the history will be if the history will indicate about the ICP, and then examination, and then investigation. So investigations which will point towards the diagnosis would be LFTs, including bile acids. So bile acids, if more than 100 micromole, then it will be most likely chance of having cholestasis of pregnancy.
Okay. What is the role of having other investigation apart from LFTs and bile acids? And when should the hepatology specialist advice be sought?
Okay, so if other investigations such as biochemistry, including complete blood count, LFTs, bile acids, and ruling out the hepatitis serology, then ultrasound of abdomen to rule out any hepatosplenomegaly. So if ultrasound would be abnormal, or bile acids would be higher, then I will involve hepatologist in this case just to rule out other pathologies.
Okay, so apart from the bile acids, you did ultrasound scan, right?
Yeah.
Anything else that you would like to do?
Mm.
Okay, and in which patients you wanted to do these extra investigations?
The patients who will present with more severe symptoms, and
Okay.
yeah, and with the fulminant hepatic failure, or with the presentation of health would be there, then I think I will refer to the hepatologist.
Okay. So what are the maternal and fetal risks?
Okay, so maternal risk with this condition, maternal risk would be a deterioration of maternal hepatic liver function, liver dysfunction, and coagulation impairment, and that is coagulopathy, and maybe low platelets as well. And fetal risk would be sudden, small for gestational age fetus, IUFD, and then meconium aspiration,
Okay.
and fetal compromise during labor.
Okay. So can you discuss the management of women with ICP?
Okay, so management of women with ICP will depend upon her condition and upon the gestation. I will prescribe her. So first of all, conservative measures I will prescribe after doing investigations. I will prescribe her anti-emollients, and antihistamines for the control of her itching. And then I would like to start her on ursodeoxycholic acid, and then I would explain her about the management of her labor. I will explain her about the sudden risk of unexpected risk of fetal demise. So based on that, frequent monitoring, frequent hospital visits, including ultrasounds for the fetal well-being. And then I will also offer her plan of induction after 38 weeks of gestation.
Okay. So for all the patients, you will go for induction at 38 weeks?
No, for the patients who are having high bile acids.
Okay. And can you discuss the future pregnancy care plan?
Okay, so future pregnancy care plan would be based on her history. If she had previous history of intrahepatic cholestasis, or there is presence of family history there, then she will be at risk of future pregnancy associated with the same condition. So I would ask her to book herself earlier in the obstetric-led care so that we can monitor her with the LFTs and bile acids.
When you will do the LFTs and bile acids?
At booking.
Okay, good. So, Sabine, you still have 4 minutes to go.
Yeah, because I just know applied clinical knowledge. I forgot a whole guideline.
Okay, don't worry. So thank you for volunteering for this station. The structure discussion, you have to be very thorough with your guidelines, because the examiner have, like, just if you have to be very perfect, because with the patient you can, with the play of your words, you can try to communicate with the patient, but you have in the structure discussion, you have to be very perfect in your applied clinical knowledge. So when are you going to appear in the exam, Sabine?
In May.
In May, okay. And yours one is oscillor as well?
Yes.
Okay, so Sabine, I would suggest that this is a very important guideline of obstetric cholestasis because it has recently come, and there can be a chance that this whole guideline can come as a structured discussion or even as an SPT. So I would suggest that the slides today, which I'm going to show you from now, because your exam is very near, so you just cram up these lines, and if the station comes in exam, you have to be very thorough in the guideline. Okay, so
Yeah.
the guideline is very different from the previous one, and they have very it's good because they have very perfect with the numbers. At what station they are going to do the induction, for how much bile acids. So I'm just going to show you in a short while the slides. Okay, so try to just cram up these slides for your upcoming exam.
Okay.
Okay. Yes, Farah is saying classification according to level of bile acid, mild, moderate, severe. Yes, that's perfect. That's right, Sabah. Farah, and Aisha is saying, can I also attempt a station? So I appreciate your participation, Aisha, but we just had 2 stations for participation today for practice. But inshallah, I hope to see you all for the November preparation. And inshallah, we'll be conducting regular sessions, and everyone will be given a chance to participate and speak. Okay, so how to classify ICP? The first question. So intrahepatic cholestasis of pregnancy. We cannot confuse intrahepatic cholestasis of pregnancy with any other medical condition. Like you said, Sabine, acute fatty liver, preeclampsia, blah blah blah. So these things, intrahepatic is
Diagnosis of
characterized.
exclusion.
Yeah, diagnosis of exclusion. Perfect. So it is a multifactorial condition. It is characterized by pruritus in the absence of skin condition. So you have itching, but you don't have any skin condition, right? And you have with the abnormal maternal bile acid concentration. All right, so itching, no skin condition, but abnormal bile acids. This is your intrahepatic cholestasis of pregnancy. And once they say that, how do you classify ICP? So now you narrow down. So now you know that you only have to classify ICP. So then we'll classify ICP depending upon the level of bile acids. Okay, I'll show you the slide in a bit. In the UK, ICP affects 0.7% of the pregnancies in the multi-ethnic population and 1.2 to 1.5% of women of Indian, Asian, or Pakistani Asian origin. Okay, so how do we classify? This is how we are going to the terminologies for the pregnant woman with itching of normal skin. So if the upper limit of normal bile acids in pregnancy is 18, if it is less than 18, we don't need to worry. If it is, we will call it as if patient has itching and patient has itching and the bile acids concentration is less than 19 micromole per liter, it will be gestational pruritus. So the diagnosis of ICP will be started from bile acids of 19 onwards. 19 to 39, it will be called as mild ICP. 40 to 99, it will be moderate ICP. And severe ICP is when there is itching and raised peak bile acids more than and equal to 100. Okay. So Sabine, you have to cram up these numbers, right?
Yes.
Yeah. So this is the classification. Then how should the diagnosis of ICP be made? So again, we need to just cram these lines that the diagnosis of ICP should be considered in pregnant women who have number one, itching in the skin of normal appearance. This is the first thing. And then the second thing is raised peak random total bile acids concentration. Raised peak random total bile acids concentration of 19 micromole per liter or more. Okay, so it doesn't has to be a fasting bile acids. It can be random peak, raised peak random total bile acid. Okay, and the diagnosis is more likely if it is confirmed that itching and raised bile acids are resolved after birth. So if the patient has ICP, the bloods and the itching has to resolve after birth. Otherwise, if it is not resolved after birth, then we'll have to think about other conditions, right? So if we have suspicion of ICP, you will take a structured history and examination so that other causes of itching and liver dysfunction can be excluded. Now, patient has persistent itching, but her LFTs and bile acids, they are normal. What will you do? You will repeat the test after 1 to 2 weeks. Okay. If the resolution of itching is associated with normalization of bile acids and LFTs during the pregnancy, then the diagnosis of ICP is unlikely to be correct because ICP is a constant condition of the pregnancy. It will only be resolved with the birth of the baby. Okay, so the only cure is the birth. So if the ICP, if the itching and bile acids, both of them have resolved during the pregnancy, then it is unlikely that it is ICP, right? So the third question was, what is the role of other investigation? So what can be the other investigation? The other investigations are number one, viral screen, autoimmune screen, and then an abdominal scan to look for gallstones. Okay, so these are some other investigation, and in which patient you will do them additional testing. These will be done in patients who have atypical symptoms. So what can be atypical symptoms? Like patient is having fever, patient is having jaundice, these atypical symptoms. So in patient with atypical symptoms, presence of relevant comorbidities or early onset and severe ICP. For example, you are at 20 weeks, patient is having these symptoms and very severe itching. So you will then think about other investigation as well. Okay, so we'll also consider postnatal investigation in women in whom resolution of abnormal LFTs is delayed or does not occur. Okay, as I said earlier, that if it doesn't resolve after in the postnatal period, then we'll have to consider other investigation. And the indication for specialist hepatology advice is also the same. So anyone with severe, very early atypical presentation will do extra testing and will refer to the hepatologist. Then comes the maternal and fetal risks. So in the maternal risks, you were talking about that platelets and all the stuff. Actually, when you know that is ICP, then you will have to stick to ICP. You cannot deviate from this. So in the patient with ICP, they generally don't have any grave problems. They just have itching, which is very bad, and that can markedly affect their sleep. But they are also at increased risk of preeclampsia, of GDM. They can have symptoms of cholestasis like dark urine, pale stools, although that can be infrequent. Steatorrhea may occur and jaundice is rare. Okay, And then the fetal risks are, so you have to be very particular in your words. Just say and cram up the lines of the guideline. And very important to mention the reference of guideline in structured discussion. In every structured discussion, make your habit that at some point you will say it to the examiner that according to the RCOG guideline of intrahepatic cholestasis of pregnancy, this. Okay. So then fetal risks are, try to avoid other words like fetal demise, this and that. Just be particular in saying the guideline words. Okay, so fetal risks are stillbirth, preterm birth. There's a risk of meconium skin liquor, and of course, admission to the neonatal unit. So then comes the management of women with ICP. So whenever the question comes to discuss the management, you have to start from the very beginning, from the history taking, not from the treatment directly going to the treatment. Okay. So starting from the history, in the history of presenting illness, you will ask about the current duration of pregnancy. How is the pregnancy been so far? How are the fetal movements? Then you can ask about the itching symptoms. When did it started? Any particular pattern as to when and where on body it is happening and bothering her the most? Any skin rashes or skin changes? Any change in color of urine or stool? And in order to exclude the other causes, you can also ask that if there is any fever, body aches, flu-like symptom, to exclude any viral illness. How is the appetite? If there is any sickness, nausea. If the patient is having any pain in upper part of abdomen, to rule out gallstones, and any recent history of traveling. Okay, and then of course so it has to be a structured and focused history. So we don't have to say the complete template, only the important points of ICP. So if the patient has previous history of ICP, she's at increased risk of recurrence. If there is any family history of ICP, medical history of previous liver diseases, gallstones, personal history of alcohol is important because that can worsen the condition. Then we will perform an examination. Where we will look for the skin changes, if any, and look for the scratch marks because they might be present in the patient with ICP. Then antepartum care. So you can say that according to the RCOG Green Top guideline of ICP, the antepartum care will be provided in a consultant-led unit with a neonatal unit. In the structured discussion, you can use all the jargons and all the fancy words that you want to use. Okay, so there is no worry about that. We will repeat the LFTs and bile acids after 1 week. And then subsequently, we will decide on individual basis. We'll ask the patient to keep a close eye on the fetal movements. We will monitor the blood pressure and check for proteinuria at every antenatal visits. According to the RCOG Green Top guidelines, CTG and ultrasound do not predict or prevent stillbirth in ICP. And there is no treatment to improve pregnancy outcome or serum bile acids. However, to help with the patient's itching, we can use topical emollients. Antihistamines can be used to help with the sleep. Also, deoxycholic acid can also reduce itching. Cool baths, loose fitting clothes, all these can be used to help with itching. Vitamin K will only be given to patients who have abnormal prothrombin time. Okay, so we don't need to give vitamin K to everyone. Then the timing of birth will be according to the severity of ICP. So in case of mild ICP, where bile acids are between 19 to 39 micromole per liter, we'll consider planned birth by 40 weeks. Because, why? Because the background, the risk for stillbirth for mild ICP is almost the same as the background risk. Okay, so planned birth will be by 40 weeks. However, for the moderate ICP, where the bile acids are between 40 to 99, we'll consider planned birth at 38 to 39 weeks. Because in this situation, for the moderate ICP, the risk of stillbirth is same as the background risk until this gestation. And after this risk of stillbirth is increased. So that's why we are going to do an induction of labor at this gestation. For the severe ICP, where bile acids are equal to or more than 100 micromole, we'll consider planned birth at 35 to 36 weeks because the risk of stillbirth is more than the background risk, almost 3 out of 100 women. Okay, so you have to consider induction at 35 to 36 weeks in these patients. Then in the intrapartum care will be provided in a consultant-led unit. Will aim for the vaginal delivery. Continuous electronic fetal monitoring will only be done if the bile acids are more than or equal to 100 or less if there are other comorbidities. the postpartum care will be provided, and then we will follow up the patient at least 4 weeks after birth to confirm the resolution of ICP. And how you are going to do the confirmation of ICP? By confirming the patient's itching has resolved, and also the bile acids and LFTs are normalized. Okay, so both of these things, the symptoms and bloods, both come back to normal. And then contraception. So ICP itself does not influence the choice of contraception or HRT. So all other things, the IUCD, Mirena, POP, implant, all of these are UKMAC1. However, COCP is UKMAC2 after. It can also be used if you confirm the resolution of ICP. So if after 4 weeks, the symptoms has resolved, COCP can be used, but although because the patient is postpartum, for example, is breastfeeding, you cannot use it for 6 weeks anyway. Okay. However, it will become UKMAC2. For patient who has ICP and previous cholestasis due to COCP use, maybe previously she used once in a while, she used combined pill and then she had cholestasis, then you cannot use COCP. Then you will have to use POP or a non-hormonal method, because in this situation, COCP becomes UKMAC, right? And then if the patient is requesting HRT, she previously had ICP, we are good to go, we can offer her HRT. So the last question was discuss the future pregnancy care. Of course, the chances of recurrence is increased in the subsequent pregnancy, and for that, Sabine rightly said that we'll perform a baseline liver function test and bile acid concentration with the booking blood. So we know from the baseline that how we are going to look after her during the pregnancy. So am I being clear on this intrahepatic cholestasis of pregnancy? Do we have any questions?
Doctor, vitamin K will give it in case you mean steatoria or in case of a prolonged BT. Is it oral or injection, doctor, in such condition?
10 milligram vitamin K will be given.
I mean oral or injection because she has steatoria.
Injection can be given, IM injection.
Okay. Yeah.
Yeah.
Thanks.
Thank you so much, Kuratullah and Sayyid Ahmar. So when are you going to appear, Kuratullah?
Yeah,
Thank you, Dr. Afia. Thank you so much, Aisha. Thank you, Shaista. And thank you all of you for sparing some time and join us in this session. Thank you, Mariam Zabin. You're welcome, Memona. Thank you, Anam.
Thank you,
Best
ma'am.
of luck. You're very welcome, Dr. Monica. And best of luck to all of you who are going to appear in the May exam. Try to practice the stations daily. Try to practice for at least 2 to 3 hours on daily basis.
Thank you, Dr. Laila, to give me a chance, and it was really helpful because I just didn't know anything about ICP at this time. And
no problem, dear. No problem, dear. Thank you for presenting. But that's the thing, that when you present in these courses and patients, then you come to know that because no one can be perfect, you see. We all have deficiencies. What courses can do that, they can polish your good points and they can help you to do a little bit improvement on your anything that you're lacking. Okay, so all we have to this is and just the thank you, Hajra Agarwal, Ishil, thank you all of you, Asma Sadiq, thank you so much all of you. So what I was saying is that the exam is just the exam of nerves. You just on the exam day, make sure that you have a like slept for 8 to 9, at least 8 to 9 hours, because before my exam I slept for I think 10 hours or so. On the next morning when I woke up, I was like all fresh. And don't panic, just sit back, relax, and just think that you are just talking to a patient in your clinic, and just keep yourself calm and composed. um, you know all the things, all the guidelines, and you have all the information. You just need to put it into the words, and try not to eliminate. You cannot eliminate patient from your discussion. Whatever you are talking, the 10 minutes are for the patient, so you have to follow the patient's agenda. If the patient is asking something, you can answer that, the patient's concern there and then. Don't say that, wait, first I'll have to ask some few questions and only then I will be answering your query. So these some simple things, and the basics. Try to stick to the basics, and then inshallah all of you will clear this exam. This is doable, although it is comparatively easier to the part 2 exam. Part 2 is the the toughest exam, but your communication has to be very good for the part 3 exam. And try not to because when we talk about so much about communication in part 3 exam, sometimes we forget about the applied clinical knowledge stuff as well. So those candidates who have passed the exam, like because of the COVID, obviously everyone's exams was delayed. Everyone has different circumstances from the family. Personal circumstances are different. So maybe many candidates had their part 2 exam like 6 months, maybe someone had 1 year ago, 2 year ago. So you have to make revise your guideline a little bit. So you don't need to go through the whole guidelines, but of course if you have notes from the part 2, and you can then just only read the recommendation. So for this guideline of ICP, you don't need to read the guideline. You can just make a notes of these slides, and then cram up these lines, because in the structured discussions, it's just the guideline that they want to listen from you. Okay. So do we have any questions? I'll just go quickly through the ICP slides. Communication with colleagues, applied clinical knowledge was demonstrated as sound, comprehensive, evidence-based clinical knowledge. Very important. I'm saying it again because in the structured discussion, very important to say it in the front of examiner that according to the RCOG guideline. Okay. So make sure to give a reference of the guideline. Then explanation of diagnosis, effect on mother and baby, no cure except delivery, maternal fetal monitoring, role of medical treatment, mode and timing of delivery, increased chance of recurrence. Information gathering has to be focused and relevant. Patient safety, provide information to the patient, be honest about the risk of ICP, possible complication, measures to reduce them, involving the consultant, and being honest about the further investigation, early delivery plan. So I wish you all the best to all of the candidates who are going to appear for the May. For those who are going to appear for the November, I hope to see you all in the coming sessions of the med exam for the November preparation. So we'll start from the very beginning. We'll do we'll go step by step, module wise. Do the basic, how to grab the station, the basis of the station, and then practice some some SPTs and structure discussions. So work hard, dream big, and never give up. That's the slogan for today. So Aisha, yes, in the oscillator system, you have the questions in front, but they will come like, stepwise. Thank you, Roshna. Thank you, Vibha Thakur. Roshna, thank you so much. Thank you, Aisha. So thank you all of you for joining us today, and wish you all the best for the May exam. And thank you, Gulnar. Thank you, everyone. And good night from my side. I will be there in contact with the med exam, and you can contact me anytime. Thank you so much, and bye-bye.